Good afternoon, friends. I am not in Bombay. As we have been in the past calling external speakers to add to the knowledge of our participants, this time I thought that we would, genetic testing is something which foxes all of us because it is expensive. And because even if our patient is advised by a doctor, they will come to us to ask, doctor, should I do this or should I not do this? So I have been knowing Anu Acharya, who's the founder of this company, Map My Genome. In the past, I have done a talk on genetic diseases for insurance industry with their team. So this time I reached out to her that I want to hold a talk for family physicians on genetic testing. Knowing Anu and Map My Genome, that's a very transparent and ethical company. So she immediately agreed and she gave us Neeraja to share that information. So it is my privilege to introduce Neeraja Reddy Mallardi today.
Thank you, sir.
She is a American board certified in genetic counseling. She has spent 7 years in this industry, both in clinical as well as administrative position. Currently, she is vice president of genetic counseling. And if our participants want, maybe a month or 2 months later, we will tell her to talk on genetic counseling for us so that, our patients trust us more than any other specialist. And if we can guide them better, then we'll be doing our service better. Already, we have received some questions from Dr. Aarti Mehta, which I have forwarded to Neeraja. And just to tell you all, since this is an external speaker program, this will be available on YouTube forever. There will be no time limitations. So you can see it as and when you want. Neeraja, over to you.
Thank you. Thank you so much, Dr. Asrani. This is a pleasure and a privilege for me to be here amongst all of you today to talk about genetics. Before I begin, I want to understand, can you all hear me okay and see me okay?
Yeah, please share the screen.
I will be doing that. Just 1 second. Are you also able to see my screen all right? Just 1 second. Okay.
Yes, clear as visible.
All right. Thank you so much. All right, so I'm very happy to be here today, talk about genetics. I have quite a bit of content, but I'm going to try and simplify this as much as possible. So my goal really is to help you introduce you to various types of testing, also understand which test applies when, as an overview, so that because I know some of these terms are complex, I'm sure you've seen prescriptions, heard about patients talking about terms like Sanger sequencing and next generation sequencing and whole exome. So we're going to touch base on all of those terms. And then I'm going to also give you some case examples of various disorders in the various domains of genetics. So some of these are multifactorial, some of these are single gene. So I have a couple of case examples for you, and then we'll also talk about which kind of test applies where, and mainly the red flags of when we should, refer somebody for genetic testing and counseling. So I will get started, and as Dr. Asrani said, I do have a list of questions that were shared with me, but I will also keep some time for questions and answers at the end of our sessions. In the meantime, feel free to write your questions in the chat box. So I'm going to begin at the basics, and just so that we're all on the same page, I'm sure all of us are very well aware of this. So when we look at a cell, when we look at individual cells, and we know our body is made of trillions and trillions of cells, each of the cell contains a genetic material, right? So this is packed in a component called the nucleus. So if I go into the nucleus, what do you see? You see the chromosomes. So we all have 46 chromosomes, 23 pairs. So we get one from our mom, one from our dad. Inside each of the chromosome, we have this, double wounded structure that we call the DNA helix, right? So that contains our genetic information, which is in the form of 4 letters, A, T, C, G. So just like the English alphabet has 26 letters, the genetic information just has 4 letters, A, T, C, and G. So these 4 letters in various permutations and combinations makes up your entire genetic material, right? Now, sorry. So how I look at this is my perspective and simple analogy to understand this and also to explain to patients is when you think about your entire genomic information to be a big book, think about the chromosomes to be your chapters. So the book contains 46 chapters, and inside each of the chapter, you have various pages, various sentences, which makes up your gene. So gene is essentially the functional unit of your genetic information. The gene is the one that codes for your RNA, which then so the DNA codes for the RNA codes for the protein. So that's the central dogma that we all studied about and learned about, right? So the gene is what converts into the protein, and the protein is what has a functional product in our body that has an effect, can cause diseases, can make us healthy, has various functions that we do on a day-to-day life. So this is, some of the fun facts, but important information that we need to understand genetics better. So we all actually have 99.9% of our DNA that is exactly the same. There's 0.1% that differs, and that 0.1% is what makes us unique from one another. So if you have a sequence and, one person has a T in this particular place, which is marked in red, and the other person has C. And that's exactly why those two people are different from each other. Right? So we refer to these as single nucleotide polymorphisms or SNPs. So we have more than 1 billion of such different SNPs in our body. And this is what makes us, you and me. And that is why you're different from everybody else. When we know most of these are related to, just simple variations in the way our color for hair, color for eyes, color for skin, or, how we are in terms of our personalities or in terms of our behavior. So these are what we refer to as common polymorphisms or common SNPs. So these are in the general population. We know some of these have been associated with different kinds of health conditions or chronic illnesses, right? So that we refer to as looking at these common variants or common SNPs in association with various disorders, whether it's cancers, diabetes, cardiovascular issues, or neuropsychiatric conditions like Alzheimer's or schizophrenia. We know that we can now, personalized genomics has developed so much that we can now look at these, common variants, and we understand if somebody is at risk of developing conditions like these. And if they are, then what can we do in terms of measures of reducing the risk? So I'll talk about this a little later. So until now, what I told you about is there is one subset of genetic changes, which we refer to as SNPs or common single nucleotide polymorphisms, which are generally present in the general population, and various genomic association studies have shown, large population studies have shown that some of these can be associated to be susceptible or increase the risk of people to develop common chronic illnesses that we tend to see in our daily lives. Now there is a different subset of genetic changes which we call as disease causing. So these are referred to as pathogenic in scientific terms. Right. So these are when, this is an example here in the English language, it's an analogy that we're giving. The sentence that is correctly written should say the cat ran down the hall. But if there is a genetic change, it ends up saying the cat ran down the ball. So that changes the meaning of that sentence. So it changes the way the gene should function and will end up resulting in some sort of a protein change, which ends up affecting your body. Right. So there is, you see this particular sorry, I'm just trying to see if I can annotate this. 1 second. All right. So you see that there is this particular change, which is a DNA base over here. And you see that the T was, changed instead of a C. And that is essentially why there is a genetic change that can cause a particular disease, right? So these are what we are looking at when you're looking at genetic disorders that are inherited in a family. So a simple example is thalassemia that we commonly see. Now we more commonly see conditions like autism in children, which I'm sure all of you have come across at least one family in your practice where you have seen these common disorders. So this slide is talking about various types of genetic changes that are common. And the reason I put this over here is because sometimes you will come across genetic reports, wherein they spell out these terms, and it would help to understand what this means. So these are just different mechanisms of genetic changes. So the first one, which is the original, which says the cat ran down the hall, which is the correct way the gene should have been spelled. Then there is a genetic change called missense, wherein there is a spelling change that happened where the H turned into a B. So that's a missense change. Sometimes there can be an insertion of a particular word or a gene or a couple of spellings in a gene. So the gray green cat ran down the hall. So this may sometimes lead to a problem. Sometimes it may not present with a very severe condition. A deletion means that there is a particular part of the gene that got deleted, a few letters that got deleted. This usually ends up with some sort of a presentation of a clinical sign or symptom. And then there is a duplication, which means that a particular area has come in twice instead of being once, and that again can lead to a change in further down the gene that can cause the effect of the disease. And then the last one we refer to as nonsense, which means that there is an abrupt stop of that particular gene. So the protein, if it's supposed to be a certain length, it will not build the protein to that length because the code itself that is supposed to build the protein is halfway there. It's only halfway present. So whatever product that it was supposed to build will not be completely done. All right. Fair. So I will move ahead. So the Mendelian pattern of inheritance, which I'm sure all of you have, remember from your school days and from your college, is the most common pattern of inheritance that we learn, and the most common types of conditions fall under these patterns of inheritance. So these are essentially inherited conditions that run in a family and can be present from one generation to the next. Sometimes you will see multiple people in the same generation being affected. So this is important to understand also because you will find families where you will get stories of multiple people being affected, and it will trigger that, yes, this is possibly a genetic condition. So autosomal dominant are conditions where you have individuals, where you require one genetic change for you to have the disease, right? So conditions, for example, Marfan syndrome, or more commonly, even conditions like, when we think of long QT syndrome, these are common genetic conditions related to cardiovascular diseases that we see in families where one genetic change is enough for you to develop the condition. Most of the times, one of the parents may be carriers. Some of the times you will find that this is a new genetic change that has happened only in the person who's affected. Then the other common way of inheriting conditions are autosomal recessive conditions. So you will often find these when there is a healthy couple with no family history. However, they've had multiple pregnancy losses, or they have multiple children who have passed away because of some illness, and they all have similar complaints, or that their children were born and passed away very soon after birth. So these are common genetic conditions that follow an autosomal recessive pattern. You often find that in India, given that we are an endogamous community, what that means is we often marry within the same, small community, a village, or sometimes even within families, which is referred to as consanguinity. So here we do find that the presence of these variants in the family or in the parents are more common. So all of us are carriers for some genetic change, right? 1 in 3 of us are going to be carrier of a genetic change that is related to a genetic condition. But we don't develop the disease because we have a second copy of the gene that's working just fine. So the individual is referred to as a carrier, meaning you're carrying a genetic change, but you're not affected. So when two people like that have a child, there is a 25% chance that the child may be affected. There is a 25% chance that the child is unaffected, and there is a 50% chance that the child will be carrier just like their parents would be. So when you see families where you find multiple individuals or multiple children passed away or multiple children being affected it's possible that there is an autosomal recessive genetic condition in the family that is running, that is increasing the risk of developing such disorders. Then there are other types of inheritance patterns like X-linked, wherein you only find males being affected in the family, wherein the females are usually a carrier, but they don't get affected because the genetic change is sitting on the X chromosome. So again, if you see multiple family members where boys are being affected, so a common example to this is Duchenne muscular dystrophy, which you will see very often in your practice. It's a common genetic condition. 1 in 600 boys can be affected. This is a condition where you see that boys usually have weakness, and have trouble walking or getting up from the floor. Presentation usually begins at the age of 4 to 5 years. And you will see that these are individuals where, the boys in the family or the males in the family are affected because the females are usually a carrier or obligate carrier, and they don't have a presentation that is severe. So if you are looking at a genetic change or a Mendelian, inheritance pattern in a family, you usually find that disorders run in a family. You find that, there may be a new genetic change that is not inherited in any of the parents and was not present in the parents. So there is really no history, but you find that your patient is suspected to have a genetic condition. Sometimes parents can have, be a silent carrier and may just be present carrying the gene, but they don't have a presentation. Sometimes you find that they have mild to no symptoms at all, because there is a variability in the way the expression of the disease is in the family. So here's a case scenario that we recently saw. So there's this is a new genetic change that we see in a family. So this is a 2-year-old female who presented with developmental delay, macrocephaly, which is a larger head size as compared to her age. She had imbalance in walking. She has speech delay. She's not really started talking yet. She's short as per her age. She has stubby fingers and she has fluid retention in her brain. So she has ventricular megaly and there is a spinal cord compression. So she was suspected to have a genetic condition called achondroplasia, which is usually when people have disproportionate dwarfness or short stature. So when we did the genetic testing, we found that she has a genetic change in a gene called FGFR3. And this is a gene that is most commonly associated with achondroplasia. It is an autosomal dominant gene mutation, so which means that it's not inherited. In her case, this was not inherited from the parents. We know that this particular gene, about 80% of the people don't inherit this from their family members. It is a new genetic change that tends to occur in just them. So these are natural changes that happens during the pregnancy, and you'll often find that, families feel that they feel guilty, if they have done something wrong, have they not taken care during the pregnancy. But we have to often reassure, especially the moms, saying that, there is nothing you could have done or no medications that you could have taken that would avoid this. This is a natural evolutionary process. Unfortunately, sometimes the genetic change can lead to a disease, and that is the reason why this has occurred. Right. So this is something that we have confirmed in her, and the genetic testing can also help her now with understanding the prognosis as well as the treatment going forward. Sometimes you'll see that disorders run in families. So this is a family that we have seen where we see multiple cancers in the family. So my particular patient is over here. So this is my patient who is a 51-year-old male who presented with pancreatic cancer at stage 4. And he has multiple family members with cancer diagnosis, including breast cancers, colon-related cancers in his siblings, and also in his niece. So when we tested this individual, he was found to have a mutation called TP53, which is referring to a genetic condition called Leaf-Romany syndrome, where we see that individuals have a high predisposition to develop cancers of various forms at a young age of onset. So essentially, the reason I'm showing you all of this is to also understand what type of genetic testing is usually referred at which place, and also to understand what are the red flags that we tend to see in families where we are suspecting for a genetic condition. So when we think about genetic testing, the decision about what type of genetic testing should be done is often based upon the history. We usually create a differential diagnosis, which means based on the personal history as well as the family history, we kind of list out the suspected disorders. And then the next step is to understand what is the type of genetic change that is most commonly related with these disorders. So some of these disorders can be related to a single gene change. Some of these disorders may be because of a chromosomal anomaly. So based on the type of the disorder that we are suspecting, we will decide which is the type of the gene change we are looking at, and that is what determines the type of test that needs to be ordered. So it's a sequential process that is usually taken. So when we think about genetic changes, like the previous image I had shown you, some changes are at the level of your chromosomes. Some changes are at the level of part of the chromosome and not the entire chromosome. And then there are some changes that are at the level of a single gene or single word change that is present. So if I were to look at the level of the chapters, right, the types of testing usually includes karyotyping, chromosomal microarray, MLPA, which is multiple ligation probe analysis, and then there is FISH or QFPCR. So these are some common types of genetic testing technologies that is offered when you're looking at genetic changes at a chromosomal level. All right. So karyotyping is essentially looking at the entire picture of your chromosomal information. So this is almost like taking a picture of all of your chromosomes, and you align it in a way that you identify various structures, and you look at if they are numbered correctly, meaning that you have all the 46 chromosomes that you should have, and that all of them are in the right structures, right? So it's only looking at the structure and the number of chromosomes. So this is the most common test that we will be ordering, and it's the most basic test that is usually ordered. Most common places that we would order this is when you're suspecting trisomy 18, trisomy 21, or Down syndrome, or trisomy 13, or if you've had couples with multiple pregnancy losses, especially in the first trimester, it can be due to a rearrangement in the chromosome, meaning a part of one chromosome is gone and stuck to another part of the chromosome. They don't have a health issue because the amount of genetic information they should have is there, just that it's arranged in a different manner. So the individual themselves may not have a health issue because of it. But when the embryo formation takes place and the combination of both of the eggs and the sperms come together and the chromosomes cross over, there can be a possibility that the embryo ends up getting either too much of genetic information or too less of a genetic information. And that can result sometimes in an early pregnancy loss. So when you often see in your clinic that you've had a couple who are planning for a conception, they've had 2 or 3 pregnancy losses, especially in the first trimester, within the first 10 weeks, then the first line of tests that we want to do, along with your hormonal workup, obviously, and your APLA and all of the other tests, is to look at your karyotyping in the first place. I think Dr. Manoj has a question. I'll just take a pause there. Dr. Manoj, did you have a question? All right, I'll keep moving on. Chromosomal microarray is another form of a test that you will see a report for a lot of patients, especially for kids who may have dysmorphism or have features that do not match their parents and look a little different. So you often find kids have cleft lip and a cleft palate. Sometimes you may find that there are children who may have an eye that is down slanted or up slanted, or that their ears are a little lower and are posteriorly rotated. So these are what we refer to as dysmorphism, where we may see that chromosomal microarray may be ordered in these children. So this is a test that is essentially looking for, are there regions of chromosome that is either deleted or either added. So the test is actually based on a simple logic. It has a chip that has all of your genetic information present on it as compared to the reference database. And then you're essentially, what you're doing is you take a normal control sample, you take a patient sample, you mark it with different probes and you put it on the chip. And when you run the analysis against the chip, and against your reference chromosome, if you see that there is, excessive amounts of your information, then that will light up in a different color. If you see there is less amount of information, that will light up in a different color. And those are the regions that will help you understand which region of the chromosome is either duplicated or is deleted, and what does that refer to? Are there genetic conditions associated with those regions? And if it is, then we will be able to elucidate what those genetic conditions are. Okay. Any questions, any concerns? All right. So the other test that you will commonly see, and this will be FISH. This is again ordered most commonly in people who have pregnancy where there are conditions where they're suspected for trisomy 18 or Down syndrome. FISH is usually ordered in those cases. Now this test is more or less absolute. We don't run this as often. However, you do see FISH being used in conditions like cancers, especially when they have leukemias in children. So this is a ligation probe analysis, wherein you're essentially just lighting up a part of the chromosome and you are using a probe to stick that exactly at the region that it's supposed to. If there are two lights, there are two copies of the chromosome. If there's one light, there is a part of it that's missing. So it's a simple technique where you're just putting a little light bulb and you're sending that with a probe, and you want it attached to the chromosome where it should, right? And you look at it under a microscope. That's all. So it's a fairly simple test, but also has a high risk of a negative, a false positive or a false negative report, which is why now there are better technologies that are coming up, which is referred to as QF-PCR, which is DNA based. Essentially does what the FISH does, but just that the analysis is better and the risk of having a possible error is much lower. All right. Now, when you are looking at a single gene change, so until now we were talking at the chromosomal level, right? Now we are talking at a gene level. So on the gene level, you will hear about two different technologies. One is next generation sequencing, which is essentially looking at all of the genetic information using an automated technology. So I think about it like a large fish net, where you're trying to look at everything and you're just using a fish net to catch any genetic changes. Versus Sanger, which is the gold standard, was the first technology when we were looking at a single genetic change, which is looking at a particular genetic change letter by letter. So it's a more manual technique. It is automated, but it's looking at a letter by letter level. So it takes a longer time. So when you have to look at an entire gene, or if you're looking at some 20 genes or 30 genes in a test or more, for example, a whole exome sequencing will look at over 22,000 genes. Sanger will get very, very expensive. So that is why the automation has helped. And that is the main reason why the cost of genetic testing is coming down in the last decade. So when you are looking at a single gene test, it's very important to understand whole exome sequencing versus whole genome sequencing. So for that, we have to first understand these terms better. So what is an exome and what is a genome? So again, these are common terms you will hear. A gene is made of two parts. One is an exome, one is a genome. And then there is the ends of it, which we refer to as the 5' and the 3'. Exons are region that expresses itself. So just think about individuals who are extroverts, they express. So exons are regions of the gene that expresses itself. Introns are regions that are, like introverts, do not express itself. When a gene has to make a protein, all of the exons come together. So these yellow parts come together, which is the exon, and it makes up your protein. All right. So when you look at your entire genetic information, just like the apple has a small size, your exon, which is the regions of your gene that are expressing itself, literally makes up only 1% of your genetic information. So your 1% of your entire genetic information is responsible for all the proteins that are produced in your body, and eventually also responsible for most of the genetic conditions, right? Or health related issues. Now, over a period of, initially in the first few years of life, first few years of genetic research, everybody thought that the intronic regions, or the region that does not express itself, was just junk DNA. So they referred it to as junk DNA because they thought it has no function. But in the last few decades of research, people have found that no, these intronic regions, or the region that does not express itself, also has a function. So now when we do a genetic test, we have two options that we usually have. One is referred to as a whole exome sequencing, one that is referred to as a whole genome sequencing. There are various types of NGS-based tests or next-generation-based sequencing. So whole genome sequencing means you're looking at all of the exons, all of the introns, essentially your entire genetic material. This is still mostly in the research realm. The reason and when we do the genomic sequencing is when we really don't know what we are suspecting. It's a completely new disorder. We have tried all other sorts of genetic tests. We know it's a genetic disorder, but we don't have a diagnosis. So this is a discovery approach, meaning you're looking for a novel new genetic change. That is when we usually refer to as a whole genome sequencing, and we would do that test, and it is expensive. Whole exome sequencing, on the other hand, is more commonly done in the clinical practice, where you are looking at the exonic regions where we know there is a genetic condition, but we cannot pinpoint at exactly what is the condition. Or the other possibility is that we know the condition, but we know the condition has some 20 genes associated with it. So that is the reason why we want to do all of these genes at the same time to save time and money, and we do a whole exome sequencing. A subset of that is what we refer to as clinical exome sequencing, wherein you do a subset of the clinically relevant genes. So this is sometimes when you want a result to be more focused, you know the subset of disorders you're looking at, and you want to save money for the patient. Finally, the smallest subset is a panel test, wherein you're looking at the small subset of genes that are related only to that particular disorder. So if I'm looking at just say breast cancer, I'm only going to look at genes that are related to hereditary forms of breast cancer. Or if I am only looking at diabetic related, early onset diabetic related genes, and I'm only going to look at that subset of genes. So this costs lesser, and you have results that are only pertaining to that subset of genes. But if you are not sure of the diagnosis, then you may have to do follow-up testing, either a clinical exome or a whole exome, to understand what gene was related to this. All right, so all of this was for us to understand when do we identify somebody, refer somebody with a personal or a family history of a genetic condition, and when to make that referral, right? So you will often see families coming to you, and I truly believe that your general physician really is the person who knows the family and the patient the most, because you might have met the family members, you might have met your patient multiple times, you've seen them over a few years, so you know their prognosis, you know their condition, you know if the symptoms are worsening, if they are getting better, if they are just at where it is. So I think you will be the best historian for a lot of these pointers that I'm going to make. So if you see that there is a personal history of somebody with an intrauterine growth restriction, stillbirths that have happened, or anomaly during a pregnancy, they should be referred for genetic testing. Significant developmental delay in a baby, failure to thrive, children with autism or autism spectrum disorders, and the frequency of this is increasing quite a bit. So you will often find families coming to you and telling you that their child requires therapy or is suspected to have autism. The usual mean age of onset of diagnosis is about 18 months to 2 years. Regression of milestones or a skill. So a child has already learned to walk and run and do their regular activity, but suddenly the parents are saying that they have difficulty in walking, they have imbalance, they are finding it difficult to get up from the floor. These are signs that you should refer them to consider genetic testing. Regression of milestones, sorry, I went over that. History of seizures. So either febrile or non-febrile seizures, they are persistent, and they may sometimes also be associated with regression of milestones, or with developmental delay, or with other health concerns, having congenital anomalies. So these should be, again, think about genetics when we see these. Cancers in the family, especially young age of onset, or you see that there is a lady with a breast cancer under the age of 45. Ovarian cancer at any age should be referred for genetics. If you see a child with a retinoblastoma, a sarcoma, a brain tumor, these are again things that we would refer for genetics. If you find that there is a male with a breast cancer diagnosis or a metastatic prostate cancer under the age of 50, we should refer them to genetics. So these are important pointers when we think about oncology. Neuromuscular disorders. So you see an adult who was hale and hearty and was fine, and suddenly they complain that they have imbalance in walking and they have weakness in their legs, and this seems progressive, and they have trouble going for a grocery shopping or going to their car at the parking lot, or that they complain that they feel like they have abnormal movements in their hands, their eyesight is drooping, or they feel really fatigued, especially after exercising. These are all symptoms of neuromuscular disorders and should be referred for genetics. Early onset dementia, usually before the age of 60. So we think about early onset dementia, especially when you see symptoms in the 50s and the 40s, especially for Alzheimer's, Parkinson's, frontotemporal dementia. These are all conditions that a very small subset, about 2 to 5%, are inherited and can follow a Mendelian pattern. So you will see multiple family members with a condition. If that is the case, then they should be referred for genetic testing. And ideally, the affected person should be tested first in all of these cases. Sometimes you will find that family members come to you with a story, but the affected person is either unavailable or not living. In those cases, you can refer their immediate relative, the first degree relative, for genetic counseling. Now you have somebody who is healthy but complains about a family history of multiple pregnancy losses, cancers in the family, previous children who have passed away or deceased at a young age, soon after birth or a first few months of life with a suspected genetic condition, consanguinity. So mostly consanguinity itself does not qualify for genetic testing. However, we recommend carrier screening, which is a test where we look for and screen parents for common variants for those autosomal recessive conditions. So this is really important. You will find a lot of families where there is intrafamilial marriage. So we will recommend genetic testing for them. Previous child, diagnosed with a genetic condition and they want to conceive another pregnancy, they want to plan for another child, the previous child should first be worked up and have a full diagnosis before we can recommend the recurrence risk or tell them what the chances are for developing another genetic condition. Multiple family members or multiple generations with similar complaints of conditions should be referred for genetic counseling. There may be a genetic condition that kind of summarizes all of the symptoms that we are looking at in the family. Now, another important factor that I want to talk about here is, multifactorial disorders. So this, one of the main reasons I brought this up is also this was a question that a lot of individuals have asked and talked about, and I think it's important to understand how we deal with this. So common conditions like psychiatric conditions, anxiety, depression, bipolar disorder, schizophrenia, all of these fall under the realm of what we refer to as a multifactorial disorders. For that matter, even cancers, aside from 5 to 10% of cancers, the remaining cancers are multifactorial in nature. So what I mean is that along with genetics, there is environmental influence, there is your lifestyle, there is your diet and life events that can influence your risk, right? So specifically, I want to talk about the mental health illnesses for a minute. So this is how we view this in the genetic world. We know that if the individual is a jar, there are certain genetic factors that can increase your risk or make you more vulnerable to develop mental health illnesses, whether it's anxiety, depression, schizophrenia. Then there is your environmental factors or your life events that can add to that. So you are somebody who's born with these yellow balls, which are your genetic factors that is already half filled your jar, right? As your life moves on, there are experiences that is making you more vulnerable to develop some of the psychiatric conditions because of certain life events. And if that goes up and your jar fills up, then you're likely to develop these genetic conditions or these psychiatric illnesses in your lifetime. So what we know about psychiatric illnesses is that we know that 50% of individuals who have schizophrenia will have a family member who has a history of schizophrenia. We know depression is very heritable. We know bipolar, 60 to 80% heritability is present, but we cannot give an accurate number of, what is the chance that your son or your sister will develop bipolar or schizophrenia. There are genetic testing that has been done. We do know susceptibility related genes associated with some of these conditions, but again, it does not give us a clear picture of what is the exact risk that can come up for some of these individuals related to these disorders. So we know that it increases your risk, but it's, we can't give you an exact figure for that as of now. But when we see these families for genetic counseling, our emphasis really is on the one fact that yes, genetic testing is available, and often people do choose for the genetic testing, but it may not give you a conclusive result. At the same time, we also talk about the importance of adapting to the risk, talk about therapeutic interventions even before the symptoms occur. So as a family physician, if you're following up with families, do talk to them about intervention as a preventative option, because understanding and finding resilience and coping mechanisms that are healthy can actually reduce your risk of developing symptoms because of the psychiatric condition. So we do offer genetic testing for psychiatric conditions with understanding that the patients are comfortable with the uncertainty and inconclusive results. At the same time, our focus is also on what can and how can we manage and reduce the risk of developing some of these conditions. All right. So when you see families where you have a young onset of psychiatric conditions, another possibility is that this can be a part of a spectrum of genetic conditions. So an example is a condition called 22q11.2 deletion, or also DGeorge syndrome, wherein we find that a lot of the kids, younger kids, in their late teens, often are diagnosed with schizophrenia. We know that there is a genetic predisposition to it when somebody has a deletion in this region of the chromosome. So if you notice that there are young children, young individuals with a diagnosis, and they have additional health problems or suspected to have additional health issues, and they could be referred for genetics for a better assessment. All right, so I'm going to come back to chronic illnesses, and I do see a lot of questions about common health conditions, and I will take specific questions at the end of the call today. So chronic illnesses, including your lifestyle related issues like heart diseases, strokes, obesity, these are all conditions that are multifactorial. There is a genetic basis to it, but these mostly genetic bases are coming from the SNPs, the single nucleotide polymorphisms that I mentioned previously, where these are common variants in the general population. Having those variants will increase the susceptibility or predisposition to it, but it does not directly cause, that alone is not enough for you to have the disorder. So along with that, you will also have your lifestyle dietary factors, right? So preventative healthcare essentially focuses on detecting the disease early, and we want to have an opportunity for treatment and improve outcomes if it's caught early, and identify ways where we can reduce the risk of developing the disorder itself by altering your lifestyle as well as your dietary factors. So components of the multifactorial disorders includes your genes, your lifestyle, environment, and family history, right? So I'm going to break down this image and help you understand this. So let's say that there is this individual in scenario 1 who has type 2 diabetes, right? And is at risk of developing type 2 diabetes. Now, we know that variant A, if the person has variant A, the risk is higher to develop type 2 diabetes. If the person has variant B, the risk of developing type T, the risk of developing type 2 diabetes is lesser, right? Now, in scenario 2, the person who has the variant A, where your genetic predisposition is higher, is also the person who is smoking and drinking alcohol. So his risk starts to shoot up because now you've compounded your genetic risk along with your lifestyle factors. On the other hand, the person who had the variant T, which is referring to a low risk, is also somebody who exercises and eats healthy. So the risk eventually comes down. Now let's consider the reverse. The person who has the genetic variant A, which is associated with a higher risk of developing type 2 diabetes, is the person who is exercising and is eating healthy. They start to reduce their risk eventually. The person with the variant T, who did not have a genetic predisposition to develop type 2 diabetes, is the person who is smoking and is drinking alcohol. Their risk starts to go up. So what this essentially is trying to tell us is that the genetic predisposition alone is not sufficient for us to have the condition. If you know that you are susceptible genetically to develop some of these chronic health related issues, if you are able to modulate your personal and your dietary factors, as well as screen and monitor for these closely, the chances that you will develop these conditions are low. and the chance that you will develop the condition at a much older age improves, right? So this is our goal when we are doing a risk assessment, when you are doing a genetic testing for these common conditions, is to assess for people who are at a higher risk and identify that cohort, and then help them understand what are the things that they can do to reduce their risk. And they assess the risk of, the cohort of people who don't have that high genetic risk, right? So personalized genomics essentially is helping us to identify these life-threatening conditions early. You want to identify the way you can mitigate those health risks, derive at the best fit treatments. So essentially, you want to customize the management and the treatment plan for that particular individual and help them improve their quality of life. All of this put together obviously reduces your healthcare costs, because a person is going to spend less on various kinds of medications and tests, etc. So when you think of common conditions like type 2 diabetes, you think of obesity, common cancers like lung cancers, and common cancers such as thyroid and bladder cancers. A lot of these common SNPs are the ones that we look for. So for example, at Map My Genome, we do various tests called Genome Patri, we do MyFit Gene. So these are all tests that are looking at various types of chronic health illnesses and trying to identify if there are genetic predispositions for these individuals. If there is a predisposition, then we help them understand what are the lifestyle measures or things that we can do to help them reduce the risk of developing those illnesses over a period of time, as well as screen for those illnesses. Okay. Then another topic of interest that is commonly brought up is pharmacogenomics. So this is obviously a common practice that you see now, that individuals are looking at genetic testing to understand which kind of medication will work and which will not work. So when you're looking at pharmacogenomics, we know that certain genetic markers can help us identify if the drug has an adverse reaction or has a toxicity for us. Another set of markers can help us understand if the drug is actually efficient and is working for us. So your best medication is the green part of this graph, which is the medication is actually beneficial and does not have toxicity, right? And we all fall at various parts of the spectrum. So the genetic factors alone does not decide the drug metabolism. We do have intrinsic and extrinsic factors. So extrinsic factors like various drug-to-drug interaction, lifestyle habits, your diet, and your environment. Intrinsic factors include your age, your gender, your organs, function, disease, pregnancy. All of these are things that will decide how your particular drug will metabolize in your own system. So all of this put together, and then the genetics will determine whether a particular medication will work well for you or will not work well for you, right? So when we do a genetic testing for pharmacogenomics, the two major benefits that a patient gets is, one, we understand if there are chances for an adverse reaction. So a good example for this is a drug called warfarin, which is a blood thinner that we all know. We know that if somebody is predisposed to have excessive reaction to warfarin, they actually have a high risk of bleeding out. So there is a very high chance of an adverse reaction when somebody takes warfarin when they are predisposed for excessive bleeding. Another, obviously helpful output of this test is understanding which of the therapy will be effective. So we know, for example, psychiatric patients, about 70% of them have a therapeutic failure because the medication doesn't work for them. So often we find individuals who are taking psychiatric medications take up the pharmacogenomics test to understand which class of medicine will work for them, which will not work for them. So this is another use of genetics now in the current world of, of treatments and for analysis. So I want to give you one example of, one of the personalized genomics tests and how this would help. So there is a 30-year-old male with a BMI of 21 who's healthy, but his father died suddenly at the age of 45 with 2 episodes of syncope. He himself has never had a preventative health checkup that was done. So this guy is 30, so obviously common things you'll hear is, why should I even screen at such a young age? I'll get it done when I'm 40 years old. Or that he would say, these are age-old diseases. I don't have issues like diabetes and vision-related problems, so what's the point? A few things to be aware about is that, 30 is actually not young to start screening. We would start screening at that age, especially if there is a family history like his, where his father has passed away at 40 with a sudden cardiac arrest. These are conditions that can be associated with conditions like long QT or Bermuda syndrome, which is a heart rhythm related issue. Some of these are genetic, so he can understand if he's predisposed to it. He can take steps towards, preventative health screening, as well as understanding precautions in terms of lifestyle related changes that can reduce his risk of developing such conditions for himself. So it is something that can be useful for him as well. So I think I want to lastly say that, genetics is complex. Even though I've been in this field for a few years now, I do find that, there are new things to learn every day, and it is a growing field. There is a lot of research that is being done. So genetics is complex, and it definitely requires a multidisciplinary approach. So as your practice, brings in a lot of the personal and the family history, as I mentioned, I think you all know the family is the best. So their stories, the documentation of their diseases are really important, and we often rely on those to help us understand the correct diagnosis. Personal history, especially evaluation, clinical examination, whether it's a child, whether it's an adult, understanding those are really important. Genetic testing, especially appropriate genetic testing. So often in the field, I've noticed that the tests that are being done are not appropriate. It's not the right test that should have been ordered, and we end up asking the patient to go through another test, and it's very frustrating for them because these are expensive, it takes time, and it's a lot of anxiety. So appropriate testing is really important, and I cannot stress upon the fact that pre-test and post-test counseling is very important for the patient. It is important for the patient to understand the implication of the test, because these are information that is shared within a family. It will have implications for their children, for their siblings, for their parents, for their extended relatives. So this is something that they have to understand. It will have implications on their own health in terms of screening, management, as well as treatment. And for some people, even insurance. So these are things that we need to talk about even before we get into testing. And then post the testing, want to understand how do we really apply and make a plan that is working for this particular client, right? Continued follow-up is extremely important. Again, we rely on you a lot for this, because as genetic counselors, we may see the patient a couple of times, but you all follow up with the patient much longer. So often you will see reproductive implications in the family. You may identify new family members with the diagnosis or the suspected disease, and you also see the management come into place and in plan. So I often find that you all will be the center of this entire picture, honestly, and all of the puzzles of this picture. And that key, person is the history that we are relying on. So we will rely on you a lot if we need the right diagnosis, the right history, right? So I'm going to stop talking and I'll take questions. Dr. Asrani, do you want me to start taking questions from the chat box, or would you like to open the floor?
Neeraja, someone has some network issues. So, can start.
I'm sorry, I couldn't hear you very well. Your voice is cracking. You want me to read out the questions and go through them?
Yes.
Okay, I'll do that. All right. So one question that we have here is ATCG is the gene, then what is FGFR? No, so the ATCNG is essentially the nucleotides, they are the DNA base. So I'll go back to this image. So that is what makes up your entire genetic information. They just stand for 4 chemicals, A, T, C, and G, that makes up your entire genetic information, right? And so yeah, this one. So you see that there is A, C, G, T, and all of this will be these 4 letters in various permutations and combinations, right? And they make the double helix structure of the genetic information or the DNA. FGFR is a DNA, which means it's the gene. It is a part, so this section here that you see, so it's a section of this DNA that is your sentence that makes up your gene. Okay, so DNA is your letters, gene is the sentence. So FGFR is a gene that builds a protein that helps us in the growth of our skeletal structure, right? I hope that's clear. So A, T, C, G are the various letters, and all those letters put together when they make a sentence is your gene. One of the gene is FGFR. All right. Where are these tests performed? Cystic fibrosis, single ventricle genetic disorder, and single ventricle genetic disorders. Okay, yes. Cystic fibrosis, yes, is a genetic disorder. Is in fact one of the most common genetic disorders. It follows an autosomal recessive pattern. So you will see that kids have with cystic fibrosis, have problems in breathing often. They will have a lot of cough infections, pulmonary infections. A lot of times they may have presentation even during the pregnancy in various forms that we identify. We do perform these tests at Map My Genome, the whole exome, the clinical exome, all of the diagnostic tests, as well as the personalized genomics and the pharmacogenomics. All of this we do at Map My Genome. So yes, cystic fibrosis, if there is a family that has a previous history of cystic fibrosis, we would recommend genetic testing for them. Single ventricle defect, I'm not sure what exactly you're referring, but there are genetic conditions that does affect your brain as well as your heart ventricles. So what are the advantages of genetic testing and the cost factor? Very good question. So advantages of genetic testing are various, starting from the right diagnosis. So you will often find diagnostic odyssey, which is a journey of a family who is suffering to get an accurate diagnosis of a genetic disorder. Sometimes this spans to be 5 to 7 years. So imagine a family with a child or a family with an individual who has some sort of a health issue and is just running from pillar to pole to various areas of medicine, various specialties, but just does not have a diagnosis. That can be very challenging. And genetics is an area where our first focus is identifying the correct disorder, making the right diagnosis, because that can help us with the correct management and the treatment and screening. Often when there is a genetic condition, the individual may be at risk of developing other health-related issues as well. So it is important that we screen that person for other conditions. And we cannot do that if we are blindsided and if we don't know what the genetic condition is in the first place. So this is one of the main reasons why we want to do a genetic testing. Second is the reproductive implication. So understanding if this runs in the family, who all are at risk, and identifying them. And also what is the chance this will happen again if the couple is planning for another pregnancy. And third is to help the person also get in touch with other families with similar genetic conditions or groups where they manage individuals with similar genetic conditions. Cost differs depending on the type of test. Karyotyping is just a few thousand rupees. It's some 3,000 to 5,000 bucks. Whole genome sequencing is 80,000 rupees, close to that. A whole exome sequencing, you can get it anywhere between 15 to 20, 25. So it differs. Again, the type of test is dependent on your suspected genetic condition, and based on that, we would give the type of test and the costing. Some people, it may require more than one test for us to get to a diagnosis. Okay, that is also possible. And sometimes it's also possible that you do a genetic test and you don't find the result. For example, we do test a lot of children with autism or suspected with autism spectrum disorders. And we know only 30% of kids with autism have a single genetic cause. So only 30%, so if I were to test 100 kids with autism, only 30% will find a genetic cause. So sometimes you do a genetic test and you don't find a result also. But we do prepare the patients for all of these scenarios during the pre-test call. So what type of test would be required if a person develops type 1 diabetes in adulthood, as type 1 is seen in childhood? So often you do find type 1 in early adulthood. That is something that we have seen occur. It is an autoimmune condition. Genetics is not, it's a little complex. It's not straightforward. There are some genes related to type 1 diabetes, especially pancreatitis related genes. So we could test for those, but it depends on the history. I may have to take a look at the history in more detail. What type of test is available for MODY as well as polycystic kidney disease? Good question. Both of these are common conditions. Single genes, both of these. Polycystic kidney disease is quite common. We will recommend doing a whole exome sequencing for both of them, both for MODY as well as polycystic kidney disease. If we are 100% sure of the diagnosis and we are only looking at, for example, with ADPKD, the autosomal dominant polycystic kidney disease, there are only a few genes. So we could do a small panel. MODY, on the other hand, is more heterogeneous. There are multiple genes related. So we may have to do something like a large test, like a whole exome. Bronchial asthma patients. Bronchial asthma is multifactorial. Now, there are these common single nucleotide polymorphisms related to it, but that alone does not, it's a predisposition, but that alone does not increase the risk. So when we find that somebody is predisposed, we tell them to be, keeping a close eye on allergies, exposure to pollen, cold weather, mites in the house, to dust. All of these are things they have to be careful with, because that will likely trigger the asthma, right? Should genetic tests be done for normal pregnancy in women above 35 and to decide genetic medicine for cancers? So the first one, yes, we do recommend genetic testing for women above 35. These are usually referred to as NIPT, or non-invasive prenatal testing. It's a screening test that is usually looking at common conditions like Down syndrome, trisomy 13, trisomy 18. So women above 35 are usually go through a blood test referred to as the double marker, if you all have probably done that already, where it looks at enzymes in your blood. NIPT is a more advanced version where it's looking at the genetic makeup directly to understand if somebody has a risk for developing these conditions like Down syndrome or trisomy 13 or 18. So those can be recommended. And then aside from that, if there is an anomaly scan that shows an abnormality, or there is a prior health history or a concern in the family, then yes, we will recommend the correct testing for those reasons. Deciding the medicine for cancer, yes, somatic testing is now very common. We also offer that. Somatic testing is usually done in tumors of the individual, so that we can look for any common variants that are present in the tumor that can be targeted when they do a chemotherapy or offer a medication for that type of cancer. Now there are many targeted therapies that are available, especially for breast and lung related cancer. So those can be performed on the tumor test. So it's referred to as somatic testing. It's also done by the same methods, just that you need a tumor sample instead of a blood sample of the patient. Okay. So what about myopia? Myopia is multifactorial. SNPs are related, but it's very difficult to pinpoint at one single genetic cause. However, there are individuals and conditions where we see very high myopia at a young age of onset. A good example is a condition called Marfan syndrome. So Marfan syndrome are individuals where they are very tall, usually have a cardiac related issue. You find most people to have very high grade myopia. And these are certain conditions. There is another condition where we see something similar called stickler. So we do see these conditions with myopia, but myopia alone, we may not be recommending a genetic test for that. DVTs and deep vein thrombosis and venous thrombosis, yes, very important, because we do see these thrombophilia related disorders. So pulmonary embolism at a young age, or multiple DVTs in the family or for that person, yes, please recommend them for genetic testing. There are thrombophilia related disorders that we will test for. Thyroid disorders have a genetic basis. Yes, some of the thyroid disorders do have a genetic basis. The common hypothyroidism often does not have a single genetic cause. They have these common SNPs that they are associated with. But if you're looking at thyroid disorders where there is the cancers are present, especially if there is a medullary cancer, then yes, we will recommend genetic testing in those cases. But it does require us to assess the personal and family history as well. Patients with protein C, protein S deficiency, yes, they should be offered a genetic testing for a genetic diagnosis. You can do the blood test to detect the levels of protein C and protein S, but we do need to do a genetic testing because we can use that information for prenatal testing. So we can offer genetic testing in the next pregnancy and also identify at-risk relatives if we know the exact genetic change that is present. Okay. So autoimmune disorders, when we are looking at autoimmune conditions, yes, psoriasis, you look at systemic lupus, or you're looking at conditions like rheumatoid arthritis. All of these we look at when we do our personalized genomics tests like Genome 3, because we know there are single nucleotide polymorphisms related to it, and it is heritable. If there is a genetic test to be done, if there is a family member, if a lady in the family has ovarian cancer, first line is to test the person who has the ovarian cancer. Please recommend testing for the lady. If she is unavailable or she is deceased, then her children or her sibling can undergo genetic testing. It can be done with us. You can reach out to us and we can guide you further for this and do a counseling session for the family. Obesity does have a genetic basis. We often see there are people who have, genetic changes in genes that are related to weight gain, weight loss, metabolism of fat, and that can cause obesity that has a strong genetic basis to it. We can test for it and help them with a more systematic approach to weight loss, as well as exercise patterns that may be more suited for them. 14-year-old had acute myocardial infarction with a high LP level. Is it genetic? Yes, there can be a very strong genetic basis. If there is a history of myocardial infarction at such a young age, we will have to assess the family further to see if there's anybody else, and we will recommend genetic testing for that. Yes, I will share my mobile number and my details. So NGS, or next generation sequencing, is an automated technology under which you have whole exome, whole genome, clinical exome, and your panel test. Sanger is a gold standard older method where we check at the DNA letter by letter. Okay. When you're doing an NGS technique, which is the most common one you will see now. So if you were to order a genetic test for all the conditions we've just talked about right now, most commonly it will be a genetic, it will be an NGS. It's faster, it's cheaper, it's the most reliable at this point, right? So that will be the technique that we use. But when we pick up something on the NGS and we want to cross-check that, we use a Sanger technology. Sanger looks exactly at the change that was found, and that's it. So it just says whether this change is present or absent. That's all. So if I have, let's say, a lady who has ovarian cancer was found to have a BRCA1 mutation. Her daughter comes in for genetic testing. I will test her daughter only for the genes that was found in her mother. That's it. So I can use a Sanger at that place. But if I were to test the lady who has the ovarian cancer, then I would use a next generation sequencing, because I want to look at the entire BRCA1 and 2 gene, and probably other genes also related with hereditary ovarian cancers. I hope that was helpful. Pre-implantation genetic testing is extremely helpful. It's a very important technology. Pre-implantation genetic testing refers to a test that we usually do in the embryo itself prior, so in the 5th or 6th day of the embryo stage, prior to implanting that back in the uterus of the lady. And this can help us identify if there is a genetic change present or absent. Usually this is done when there is a prior genetic change that was identified in the family, or there is a known diagnosis present. There are also pre-implantation tests that only looks at chromosomal numbers and chromosomal arrangement as well. That is referred to as PGT-A, where you're looking just at the chromosome numbers and the chromosome structure. So more or less like doing a karyotyping in the embryo. Pre-implantation genetic diagnosis is more and more accessible now. It is expensive, but there are families who afford for it, and it requires an IVF procedure along with that. Keratoconus conditions is there a lot of dermatology conditions that does require genetic testing. We often see dermatology closely linked with genetics. So again, we'll have to study the family better in order to understand this. Thalassemia and sickle cell are the most common conditions we see in genetics. So in fact, all women who are pregnant, as per the Indian guidelines, we do recommend screening them for thalassemia. And I think this is one of the most important takeaways for all of you. Whenever you see a family or a couple with a new pregnancy, please recommend them to at least do an electrophoresis for HB, for their thalassemia screening and sickle cell screening. If the electrophoresis or the HPLC comes back positive, then they will be recommended for a genetic testing to find the correct diagnosis and the exact genetic change. If the exact genetic change is found and both parents are carriers, then we would recommend prenatal testing during the pregnancy, anytime between 11 weeks to 16 weeks. Which test is advised for prostate cancer? So if there is a metastatic prostate cancer, especially under the age of 55, then we usually first want to look at BRCA1 and 2 genes. There are other related genes with prostate cancer that we will be looking at. So I would usually do a next generation based test. Either choose a small panel that has all of these genes together or do a whole exome sequencing, depending on what the patient is comfortable with and what the history of the family has. I will share my number for further testing. Multiple sclerosis is part of multiple sclerosis is a genetic condition. Yes, some of it is acquired. So if it's an early onset and multiple members in the family, then yes, we will do genetic testing. Early graying of hair at the age of 5, yes, has a genetic correlation. In fact, there's genetic conditions where you find a forelock of a child with white hair. You might have seen pictures of these, where babies have like this white forelock at the front of their forehead. These are genetic conditions. Early graying at the age of 5. Most common reason is vitamin deficiency, but yes, we should think about genetics as well. Does HT and dyslipidemia have genetic testing? Yes. When you find individuals with very high cholesterol deposits in their skin, or having multiple family members with high cholesterols ranging in hundreds and thousands, even at a young age, with no history of obesity, no unhealthy eating, and early onset cardiovascular diseases, yes, we will do a genetic testing for them for the hyperlipidemia related disorders. Myasthenia gravis, yes, we do. Congenital myasthenia gravis is often commonly tested and we do find positive results. You will have to do a whole exome sequencing for that. Anterior horn cell disease, again, is one of the big class umbrella of disorders where often most of these are genetic in nature. Investigations advisable for female with prior history of trisomy 21, fetus is aborted, patient planning for a pregnancy. Please have the parents do a karyotyping first. That will help us understand if the parents have any rearrangements in their chromosomes. If that is normal, they can go ahead and plan for a normal pregnancy. During the pregnancy, please recommend that they have at least an NIPT done to look for a trisomy 21. When we think about maternal serum screening, which are these tests that we do in the first trimester to assess for trisomy 21, 18, and 13, NIPT has the highest sensitivity, especially for Down syndrome. It's 99.9%. So that would be advised, and an NT scan. If the reports come back positive, then it has to be a repeat test by doing an invasive procedure, has to do the confirmation for trisomy 21. So perinatal genetic test, I'm sorry, I lost the track. Prenatal genetic testing is usually done anytime between 11 and 16 weeks. So CVS, chorionic villus sampling, can be done between 11 to 13 weeks. And then after that, around 16 to 18 weeks is when we would do an amniocentesis, which will collect the amniotic fluid for testing. And post that, some doctors will do a PUPS, but it has a higher risk of miscarriage. So usually, typically, we do the testing between 11 to 18 weeks. And now, given that, the laws have changed and we are allowed to test beyond 20 weeks and termination is allowed beyond 20 weeks, we can offer genetic testing even beyond that. So that has helped us a lot, actually, because it gives us more time for a definite diagnosis. I always emphasize on this is, please encourage family members to bring in their child or the individual who's affected to test first. The main reason being that the best chance that we find the correct diagnosis is when we test somebody who's affected. Oftentimes, families make the mistake of coming back only when they have an next pregnancy, when the previous child has already passed away or is no longer available. And at that point, we are rushing against time for an appropriate diagnosis. And without the proband or the affected child, it becomes very challenging for us. All right. I think the last question that I would take here is insulin autoimmune disorders, whether mutation oriented causing hypoglycemia. Insulin autoimmune disorders are and can be genetic. Example, pancreatitis at a young age can be genetic in nature. So those are conditions where we will consider doing genetic testing. All right, I will leave my number and Dr. Asrani also has my number. So if you all have any questions or any concerns, feel free to reach out. And I'll also leave my email address here in case you all have questions or families that you want to refer to or want to just discuss a case. I'm available. All right. So I want to talk firstly, thank Dr. Asrani for this opportunity and the presentation. I really enjoyed talking to all of you, and thank you for making this very interactive. You asked a lot of good questions. I'm really appreciative of that. Feel free to reach out. Thank you, Dr. Asrani, for this wonderful opportunity, and I hope to see you all again. Thank you.
Thank you so much, Ms. Neeraja. Asrani sir is actually has some network issues, so he is unable to join back.
That's
so
okay.
we thank you so much for enlightening us on this topic
you.
and helping us know about genetic testing. Thank you so much.
Please take care. Bye. Good night, everyone.
Bye. Good night, everyone. Thank you.